that this particular bacteria has been isolated from normally sterile sites such as blood or cerebral spinal fluid, and those isolated bacteria are almost always encapsulated rather than not encapsulated. Serotypes really differ because of the surface polysaccharides that are on the outer membrane capsule. So when we look at any of the bacteria, whether it's a pneumococcal or whether it's a meningococcal, it's this sugary polysaccharide coating that certainly gives the different serotype that we see. The capsule itself is really essential for the survival of this particular organism in the blood, and it really provides resistance to antibodies. So it often does result in quite significant disease. So if we look at the causes and the particular strains that are dominant, obviously Meningococcal B is the one that raises the biggest question mark. We definitely see more cases of Meningococcal B right across Australia, and in certain age groups, but then again all across our age groups, and we'll show you some graphs a little bit later on in the presentation. Interesting with Meningococcal W, such a huge increase of notifications for this particular strain, particularly between 2014 and 2016, and even into 2017. Obviously, we've been vaccinating against Meningococcal C for a number of years. It was introduced onto our nationally funded program back in 2003. So this has become a really rare disease now. Only 4 cases were notified in all of 2018. So for all of you providers out there, you've done a fantastic job in really making a difference in the circulation of Meningococcal C disease. There's been some cases of Meningococcal Y, certainly not as many as we've seen for Men-W, but it has certainly been a strain that has been emerging. Meningococcal A, quite a rare disease here in Australia, but if people are travelling particularly to sub-Saharan Africa, it is a requirement that they would receive an ACWY vaccine, particularly if they were travelling to the Hajj. In regards to 2019 data so far, this is up to about the 7th of June. So this is just data I looked at a couple of days ago. 68 cases of invasive meningococcal disease have been reported to the National Notifiable Disease Surveillance System. From that, 1 in the ACT, 13 in New South Wales. And serotypes that they've seen there, 11 cases are the B strain, 2 Ws and 1 Y. There's been 3 cases reported in Northern Territory, 17 in Queensland, 10 of them being serogroup B, 4 serogroup Y and 2 serogroup W. 9 in South Australia, 6 of them being serogroup B, 2 Ws and 1 Y. A couple of cases in Tasmania, 13 in Victoria, 6 of those being serogroup B, 1 C, 12 were W and 2 were Y, and 10 in Western Australia. And serotypes to date were 4 C serotypes, 2 Bs and 3 Ws were the ones that have been identified so far. So we are just sort of leading really into meningococcal season. So it's expected that these cases will certainly rise over the next coming weeks and months. So how is it spread? Definitely by people sharing respiratory and throat secretions. It sounds a bit gross, really, but it's particularly seen most commonly in those saliva sharing age groups. So the really, really young children and the adolescents particularly. it does take quite close contact. So this is really important for providers to understand, to follow the instructions of the public health unit in regards to who should receive prophylactic antibiotics. If they've been identified as a close case, they will be directed to receive antibiotics by the public health unit. So if any parents come to your practices and say, my child was in that class and they've not been contacted, or they were told that they don't need antibiotics, then that is the truth. They don't need antibiotics. They have been considered to have not had a close enough contact with that particular individual. So these bacteria are not as contagious as the viruses that cause common cold or the flu. You generally can't catch them just with casual contact or breathing the air where somebody with a meningococcal case has been standing. So it really does prove a little bit difficult to catch. We've got to bear in mind that around about 20% of our peak carriage is in older teenagers. This carriage can be present without them understanding it, without them knowing that they've got it. Why does it make some people sick and not other people is really an unknown, to be honest. That carriage, that period of carriage can be quite transient, or it can last for months. Why some people carry and others don't, it's quite an unknown phenomena. So if we're looking at symptoms of meningococcal disease, either meningitis and septicemia are the two conditions that we look at. Invasive infection, definitely septicemia and meningitis, both of which are medical emergencies. So meningococcal disease really is a significant illness, and it's got an overall mortality of around about 8%, which is quite significant. Majority of deaths in these individuals will occur in the first 24 hours. It will mainly present, like I said, as a meningitis and a sepsis. They can often present together. Sepsis is exceptionally dangerous, and it is the more common of the presentations. Unfortunately, meningococcal disease can often present with really non-specific symptoms such as fever and lethargy, and babies that are a bit fussy with their feeds and won't feed well, headache, nausea, vomiting. They're really very, very common symptoms that we would see in non-threatening viruses, and this makes this confident diagnosis in the early stage really, really difficult. Around about 95, almost to 100% of children with fever and petechiae will have a cause other than meningococcal infection. However, we need to remain really highly suspicious when children present with these types of symptoms. We need to definitely reassess them, ideally by the same provider that's seen them 4 or 5 or 6 hours earlier, so they can see what the difference is. And we really need to advise carers and family members to seek further medical assistance, particularly, if the patient is deteriorating or just indeed that they are concerned and worried. These individuals can become very unwell very, very quickly. So this disease has an incubation period of around about 1 to 10 days, most commonly about 3 to 4 days, and has often been described as the most rapidly lethal infectious disease known to man. So it's certainly something that we need to really take notice of and follow your gut instinct realistically. Different signs and symptoms can occur with septicemia and meningitis, but some of them actually will coexist. They may present with some, but not all of these systems. Like I said before, that initial presentation might be quite typical of a cold or flu or a gastro or even a hangover if it's in a teenager. They may have a sore throat, they may have a headache, they may have lack of energy. But alternatively, it could actually start with sore arms or legs, aching joints or pains in the chest or stomach. So it can be really very confusing for providers to be making this diagnosis. The prodromal phase, so just that building up phase, can last up to about 4 hours in young children, but maybe as long as 8 hours in adolescents. But across all age groups, the signs of sepsis, you know, was the next thing to develop. And about 70-odd% of children do complain of limb pain, cold hands and feet. They have pale or mottled skin around about 8 hours from the onset of illness. So, like we were saying, really rapidly can deteriorate. So this classic meningococcal rash that people talk about, it happens when the bacteria multiply in the blood vessels. This bacteria then releases toxins, which in turn damage those blood vessels. So then the blood leaks out through the tissues and sits underneath the skin, giving it this initially spotted appearance and then leading into much larger purple bruises or hemorrhages, which will just cover the body bit by bit and before your eyes. So obviously these people are very sick. They can go into shock, their blood pressure falls and their circulation fails, particularly in the extremities. So amputations of fingers and toes and limbs certainly does or can occur, and obviously also death can be a result. The rash obviously can be very difficult to see on somebody with dark skin, but might be visible in paler areas such as the soles of their feet or the palms of their hands, even on the conjunctiva or the palate. So really important for providers to do a full body check for this rash if somebody is presenting with symptoms of meningococcal disease. People do talk about the glass test where you can press a glass against these particular red spots, and if they were to blanch away, then it might not be meningococcal disease, but we would hate to give people a bit of a false sense of security about that, because in the early stages, the rash may well blanch away, but as the disease progresses, the rash will stay and won't blanch away under pressure of a glass. So we've got some questions here. So is a rash always present in people with meningococcal disease? A, no, B, yes, and C, if it is going to appear, it will appear early in the disease. So we'll just give you a minute to answer that particular question. You can see your responses coming in, so keep them coming in for another few minutes. Okay, all those answers are coming in beautifully, and that's fine. Some people can't access the questions. People are just typing them into the box. Perfect. Okay. So, certainly the answer is A, and you did very, very well at answering that. The rash is not always present, so don't rely on the rash appearing. So symptoms in babies, once again, can look like any viral type illness, can be very, very easily misdiagnosed. One thing to really take note of is the level of parental concern. Parents know their babies better than anybody else. When parents are showing high levels of concern, just ask them, has Bub ever been this sick before? When Bub does get an illness, what types of things happen with the baby? And if they're saying that they've never seen the baby do this before, this is just terrible, etc., really take notice of that. So those, concerns, those perceptions of parents and patients should be really taken very, very seriously. There was a really large study done in the UK around about 10 years ago that found that almost 50% of children presenting to GPs with meningococcal disease were sent home on their first visit, and those children were more likely to die. So it is a very difficult disease to diagnose. So definitely be advising parents of the signs and symptoms of meningococcal disease. Get them to be diligent, check their baby regularly for deterioration or for a rash, and that rash may even be just tiny little pinpricks. Definitely encourage them to return or definitely get a second opinion, if their worries continue or the baby's condition definitely deteriorates. People with this particular disease are certainly at risk of complications. They may well be neurological complications. They may well be physical complications with skin scarring, limb deformity, amputations, etc. So definitely a disease that needs a lot of attention. It needs to be identified very early to give these individuals a really good chance of recovering without long-term sequelae. So if we look at the progression of this particular disease, obviously there is issues with the heart where pericarditis due to the immunologic reaction becomes very inflamed. It can get a myocarditis, so once again inflammation of the myocardium. The cardiorespiratory failure, these people will need to be on a ventilator. They can have pneumonia, renal failure, so it's really quite a significant disease. So that organ dysfunction right through to death. I mentioned before that most common this disease is seen in the saliva sharing age groups. Now these two particular age groups, the less than 2-year-olds and the adolescents, are sharing saliva for completely different reasons, and that we won't go into. But we need to be quite aware that carriage is also highest in older adolescents and young adults. These are the individuals that have close contact. They're at parties, they're at universities, they're potentially in boarding schools, etc., where they have very, very close contact. Young children, they have got quite a young immune system. This is something that their immune system is not going to recognise and fight very easily. And of course, they have close contact. They share their dummies, their bottle teats, their toys, their fists, etc., that they've all been sucking on. So we need to also understand and appreciate that these diseases are seen in other individuals as well outside of these age groups. And, you know, particularly meningococcal W, which we will talk about a little bit later on. Our immune-compromised individuals have an increased risk factor as well. Children or adults that are without a functioning spleen are at increased risk of infection with any encapsulated bacteria. Most importantly, it's actually pneumococcal bacteria. However, other bacteria such as your meningococcus as well as your Haemophilus influenzae type B also occur at, you know, quite high rates in these particular individuals. Certain medical treatments, this particular drug, you're not going to come across in general practice. It's a very expensive drug. It's given under advice from a nephrologist. These individuals are really quite unwell, but this particular medication does increase the patient's susceptibility to meningococcal infection, and therefore these particular individuals are advised to be vaccinated with meningococcal vaccine prior to or at the time of initiating the treatment. Other risk factors, chronic disease. We certainly know that people that have any levels of immune compromise are at risk of, at increased risk of infection. Definitely exposure to smokers are more likely to be carriers. Smoking is just not a good thing when it comes to any of these types of diseases that enter our upper respiratory airways. Smokers have damaged lining to their mucosal surfaces. The hairs in their nose don't work well at filtering out these particular viruses, such as flu and cold type viruses. Being a current smoker, and certainly those, you know, living in close quarters, multiple people that you're kissing, which is probably more into the teenage adolescent years, but particularly recent or current viral infection also makes you susceptible. So looking at the burden of meningococcal disease across Australia, you can see there that we had a period of time where meningococcal disease notification rates decreased, but then we've seen a rise in notifications as well. ACWY vaccination programs over the last year or so have certainly seen cases decline, but meningococcal B is now more the predominant strain. So some states and territories have been vaccinating against ACWY all of 2018, but of course we'll talk about the funded program changes shortly. So definitely our Aboriginal and Torres Strait Islander people are also at increased risk of meningococcal B disease. If we look at this particular graph, it will be quite easy to see that those red bars, which represent meningococcal B, are very, very prevalent. But you can see over time, really since about 2016 and across 2017 and across 2018, there certainly was an emergence, particularly of meningococcal W. Once again, looking at the different strains that we are seeing, meningococcal B is definitely the standout strain. Deaths from meningococcal disease also look to be declining, which is excellent news. It means that providers are perhaps diagnosing this early enough, getting those antibiotics in. We've got better treatments in our intensive care units for these particular individuals, and hopefully we will continue to see a decline in 2019. 2017 it did certainly jump up, but 2018 was much, much better. If we look at notification across Australia by serotypes per state and territory, you can see by this particular graph that B was definitely more predominant across the states and territories. It was an even distribution except for ACT, and W was also a standout serotype in 2018. Notifications, just in a different graph, so you can just see where everybody's was sitting last year. A total of 281 notifications in 2018. So we've certainly got a little way to go to beat that number this year. But like I said, we're only just really reaching into meningococcal season now. If we look at the different age notifications, you can definitely see from this graph that meningococcal B is across the age ranges, but not so much in the 10 to 14-year-olds. Very clearly, it's the standout serotype affecting young children under the age of 4. So if a parent is asking about meningococcal vaccine for their young child, we do have ACWY that has been funded on our national program at 12 months of age. But this is worth having a conversation to parents when you see them about the importance of meningococcal B vaccination, particularly in those young age groups. So we've had some changes to the vaccines and the registration of vaccines and the number of doses and the scheduling, etc., over the past 12 months. So our quadrivalent ACWY meningococcal conjugate vaccines, so these vaccines are conjugated either against, either with a tetanus toxoid or a diphtheria protein. Your Menveo can be given from 6 weeks of age, your Nomenrix from 6 weeks of age, but it is NIP funded at 12 months of age. Your Menactra can be given from 9 months of age. However, Menactra is the least preferred of the ACWY vaccines. If you are using Menactra, it should not be co-administered with Prevnar 13 because of a possible interference in the immune response to some of the pneumococcal serotypes. If you've only got Menactra available, if you cannot source Menveo and you cannot source Nomenrix, you can give Menactra, but if you are needing to give Prevnar 13 as well to this individual, then the advice is that you give Prevnar 13 first and then followed 4 weeks later by the Menactra. If somebody has mistakenly co-administered these vaccines, you do not need to repeat the Prevnar 13, but certainly Menveo and Nimenrix really are the preferred vaccines for children less than 2 years of age, for sure. We're not seeing a lot of meningococcal C vaccine given now. It's usually going to be an ACWY. But of course, now we have 2 meningococcal B vaccines. We've got Bexsero and we've got Tremember. Bexsero's can be given from 6 weeks of age, but Tremember from 10 years of age only. So if you've been giving some of these vaccines, you will definitely know the answer to these questions. So how are Menveo and Nimenrix vaccines administered to the patient? Is it in a liquid form and you just simply draw it up and administer it intramuscularly? Does it consist of a powder and a liquid that need to be combined? Is it oral? Or is it just best given 2 months after other vaccines have been given? So just go into your questions and answers box there and see what you think. Answers are coming in nice and fine. You've obviously definitely been out there administering this vaccine or these vaccines. Just another little minute or so. Okay. You did very, very, very well. Very well indeed. So the answer is B. It does come, these 2 particular vaccines do come in powder form, and you have a liquid accompanying them, and they do need to be reconstituted. And the next one, if you've been delivering Menactra vaccine, how is this vaccine given to the patient? Okay, let's just have a little look at that. A few answers are still coming in. Oh, lots of you have been giving this vaccine too, by the looks. Excellent. So, Menactra is in liquid form. So it is simply drawing it up and administering it intramuscularly. Just looking at a question here from Alice in the inbox, why is Menactra the least preferable vaccine for ACWY? Alice, I've just got the NCIRS fact sheets here in front of me, and these are excellent fact sheets for providers. So jump onto the NCIRS website, which is the National Centre for Immunisation Research and Surveillance, and it will answer lots and lots of your questions. But in the answer to yours, there is some evidence that antibody response after Nimenrix or Menveo is modestly higher than after Menactra, especially for serogroups W and Y. There is also some evidence showing that immunity decreases more quickly with Menactra than with Nimenrix and Menveo. So hopefully that did answer your question, Alice. Okay. So, who should be receiving ACWY vaccine? Definitely, we need our adults covered. We need our Aboriginal and Torres Strait Islander people covered. We need people with medical conditions that are putting them at increased risk of invasive meningococcal disease. We need them covered. This is a vaccine that should be offered to travellers, particularly travellers to Sub-Saharan Africa, for example, occupational risk, but really anybody that's over 2 months of age or 6 weeks of age who wants to reduce the risk of contracting this particular disease. Definitely, it's available on prescription for non-NIP eligible cohorts. So we do know that adolescents and young adults, most definitely, they are tending to be in crowded populations. Perhaps they are in dormitory style accommodation, military recruits, students living in residential accommodation, etc. And definitely those that are going to be covered under the NIP. So Nimenrix, of course, is available on the NIP for adolescents aged 14 to 19 years. Those that are aged 14 to 16 will likely receive this vaccine through a school immunisation program in around about year 10 level. Those students that are aged 15 to 19 and didn't receive the vaccine at school can receive it from their GP. Meningococcal B vaccine is not funded on the NIP, but here in South Australia it is a state-funded vaccine for adolescents aged 15 to up to their 21st birthday. So ACWY, like I said, it's been funded on the NIP for all children at 12 months of age. So this is from the 1st of July last year. There is now an adolescent program in the school system from the 1st of April this year. So they will, one cohort will get it as part of their school immunisation program, and then the others can access through their GP or chosen provider. So with our meningococcal B vaccines, we've already identified that young children, young babies are particularly in the highest risk category. So, but it's not a funded vaccine. Always talk to parents around non-funded vaccines and the importance of them, as well as the importance of the NIP-funded vaccines. Meningococcal B vaccine, so Bexsero, can be given on prescription to young babies that are not in South Australia. Obviously, we do fund it here. We fund a dose at 6 weeks of age, at 4 months of age, and then a booster at 12 months of age. So please talk to your parents about the risks. The only way that we can protect people from this particular disease is through vaccination. In South Australia, the funded program for our adolescents, it's going to be an ongoing program for adolescents in schools in year 10. The catch-up program is currently being delivered for year 11 students and also for adolescents up to their 21st birthday. Like I said, that program will end on the 31st of December. We've also got another catch-up program for children aged 12 months to less than 4 years of age as well. So as long as they have their vaccines in 2019, they are going to be eligible to receive 2 doses of Bexsero vaccine. So we've got another poll. should pregnant women be immunised against a meningococcal disease? What do you think is the recommendation for that? Just wait for a few more answers to come in. Okay, so that's still coming in. Okay. So just while I wait for those coming in, I'll just answer a couple of questions. So Tremember definitely can be given to adults. Anybody over 10 years of age can receive Tremember. It does have an upper age limit of 55 years, but ACWY have said that it could be given to people over 55 years of age. So if we're giving Bexsero at 6 weeks of age, they only require 3 doses in total, 2 as a primary, 2 doses as a primary course under 12 months, and then a dose at 12 months as a booster. So it's a 2+1 schedule. Unsure of how long one booster will last, unfortunately. There is just not enough data at this stage. It's a relatively new vaccine. So we just have to really wait and see. There is not any known cross-immunity generated from an ACWY, for example, into a B vaccine, a B serotype. So individuals that are wanting protection from all 5 strains would be required to have the 2 different vaccines. Will there be a catch-up program for children for Nimenrix? Not for children. The adolescents are getting Nimenrix now in the school immunisation program. But children that had received their meningococcal C vaccine at 12 months of age and are not yet in high school, certainly there is no catch-up program for them. Okay, so you did very, very well with this question, and the answer is D. Vaccines really aren't recommended for pregnant women, but of course, think about, are they at excessive risk, increased risk? Most definitely you would be offering it. It's not a live virus vaccine, so it's not totally contraindicated. Okay, so vaccine effectiveness. This is always the curly question, isn't it? You know, if we have vaccines, you know, how protective actually are they? We definitely know that no vaccine is 100% effective, or very, very few are touted as being 100% effective. So we've got to be really transparent about that. When we deliver our vaccines, we really should understand vaccine effectiveness. Vaccine effectiveness will differ from vaccine to vaccine. If we're talking about a hepatitis A vaccine, it is highly, highly, highly effective. It's an exceptionally good vaccine. Obviously, measles, mumps, rubella vaccines are very, very good, particularly if we have 2 doses. But if we look at something like a flu vaccine, where vaccine efficacy can sometimes be quite poor, but the effectiveness of the vaccine in keeping people out of hospitals, off of a ventilator and out of a coffin means it's still worthwhile having the vaccine. So we need to just make sure that people understand that even though they've been vaccinated, they could still be at risk of contracting a disease. Vaccination affords a degree of protection, and it will just mean that it's going to reduce the likelihood that someone's going to catch the disease, and certainly reduce the likelihood that they're going to become very unwell if they were to catch the disease. So we do need to talk about this with parents and always remind them to watch for signs and symptoms of meningococcal disease despite their children being vaccinated with these vaccines. So we've had great reduction in the number of meningococcal C cases in Australia since the introduction of this vaccine in 2003, and we looked at that data a little bit earlier. So definitely we know that if we vaccinate a large population of individuals, it does confer that herd immunity to other susceptible people in the community. So talk about vaccination at every point with every client. So in regards to meningococcal B vaccine effectiveness, protective antibodies against 76% of the meningococcal B strains, which is absolutely fantastic. We've just got to remember that when we talk about these particular serotypes of meningococcal B and ACWY, there's quite often other strains of that particular serotype that do circulate. So it really should be noted that the 4 strain MenB vaccines that we currently have access to cannot be expected to provide protection against all of the circulating MenB strains. So some of these strains will not express any of the protein antigens contained in the vaccine. So we just need to make people really aware that vaccination is not going to be 100% in stopping them from contracting disease. Vaccine safety, this is always something that gets talked about. How safe are these vaccines? How well tested were they? Has the government rushed them in too quickly? What are we most likely going to be seeing? But these meningococcal vaccines, particularly the 4-valent ACWY vaccines, have been shown to be really, really well tolerated. We don't tend to see significant adverse events, generally just the mild common adverse events that we see with any other vaccine. There may be a fever, there may be a headache, there certainly is likely to be injection site soreness and redness and potentially some swelling, but we do know that those minor side effects are very self-limiting, should really only last, a day to 3 days, if that. Just in regards to Menactra vaccine, yet again, the product information for Menactra states that a previous episode of Guillain-Barré syndrome is a contraindication to vaccination with Menactra, but ATAGI, which is the Australian Technical Advisory Group on Immunisation, has actually recommended that any of the 4-valent ACWY vaccines can be administered to a person with a history of Guillain-Barré syndrome. But as with all vaccines, those risks and benefits should be explained to every client prior to any vaccination. So with meningococcal B vaccine, that vaccine is a bit more reactogenic. It's a bit more of a painful vaccine, and it's going to quite likely increase fever. Particularly, we need to be careful around fever for very, very young children, which is why ACWY has recommended that prophylactic use of paracetamol with every dose of the meningococcal B vaccine administered to children less than 2 years of age. This is really because of the high incidence of fever in infants who have received meningococcal B vaccine, particularly concurrently with the other NIP vaccines. And it is recommended that that first dose of paracetamol is given around about 30 minutes prior to vaccination. If a parent shows up and you want to opportunistically immunise the baby, you can do that, but just advise the parent to give a dose of paracetamol as soon as practical. There should also be 2 doses of paracetamol administered 6 hours apart post-vaccination, and that's regardless of the presence of fever. But always advise parents to seek medical attention if they're worried or concerned, or if the fever is just not being managed. Obviously, with all of the other vaccines that we have, the true absolute contraindications for all meningococcal vaccines is an anaphylactic reaction following a previous dose of the vaccine, or an anaphylactic reaction following receipt of any of the vaccine components. So always make sure that you double check what's in your vaccines and do that pre-vaccination checklist looking for any previous anaphylactic reactions or sensitivities. Meningococcal disease is a notifiable disease in all states and territories. Whilst they do say prompt diagnosis and treatment, we know that that can be exceptionally difficult. But certainly, when in doubt, if you've got any clinical suspicion, you are better off taking some bloods and giving antibiotics. If the bloods come back that it's a negative reading for meningococcal disease, that dose of antibiotics is not going to harm that particular individual. But by not giving that dose of antibiotic, you really could be risking this person's life. So there are some invasive meningococcal disease national guidelines, and it does definitely say if there's any suspected cases, collect blood and certainly give antibiotics, admit them to hospital so they can collect some cerebrospinal fluid, etc. So definitely notify your public health unit. So we're almost out of time. So just in conclusion, so this recent emergence of MenW has been of concern, and the emergence of MenW and certainly what's appearing to be an emergence of Y certainly did prompt the government to change out the meningococcal C vaccine and implement an ACWY program. We know that people will die from this disease. People that do not die will either fully recover or they may end up surviving the disease but with long-term sequelae, such as their amputations or limb deformities, neurological deficits. We know that carriage rates are high in older teenagers, and we definitely know that our children under 2 and our adolescents are at the highest risk for this particular disease. We also know that we've now got free meningococcal ACWY on our funded program that's available for adolescents, delivered through school-based programs or school immunisation programs, as well as through GPs. And here in South Australia, we have a Meningococcal B program for our young children and our adolescents as well. I'll just have a quick look at the questions box. I think we've answered a few of these. So Alison was just asking about pathology testing. Is that for a suspected case, or are you thinking post-vaccination titers or anything like that? And that might be something that we'll take on notice. Elaine, the Nurofen issue has been raised previously. There is just no data to support the use of Nurofen in all of the clinical trials and in programs for meningococcal B vaccination overseas. Paracetamol has been the drug of choice to use. SA Health here have been asked this question a number of times, and their stance is to follow the recommendations of paracetamol. I will leave it up to the Immunisation Coalition, but yes, the slides are generally available on the Immunisation Coalition website, usually in a few days' time or a week's time. So post-vaccination titers, Alison, generally we wouldn't be measuring titers post-vaccination. The evidence is that it gives reasonably good coverage to the people who complete a course. For the current vaccines, we don't know what the booster is going to be. Definitely if people have medical risk factors, they do require additional doses and they do require ongoing boosters. So definitely look at your immunisation handbook for those recommendations. The good news is we can't over-vaccinate people. So if a patient has had a meningococcal vaccine but not sure of the type, would an extra dose hurt them? No, it wouldn't hurt them. However, they do say that the 2 meningococcal B vaccines are not interchangeable. So it would be a good idea to try and find evidence of what vaccine it was that that individual has received, most definitely. The ACWY vaccines are interchangeable. That's not going to be a problem. So I think we have answered pretty much all of the questions that are in the inbox. Thank you very much. So thank you for joining the webinar.
Thank you, Angela, for doing that webinar tonight. And yes, we will put up a recording of this webinar on our website, and we will also make the slides available as a PDF version.
Thank you very much, Suzanne, and good night, everybody.
Good night, everybody.